Hi, my name is Dr. Marysia, and I'm a cardiologist at Mayo Clinic in Rochester, Minnesota. And I have the pleasure of introducing you to today's Mayo Clinic Cardiovascular CME podcast series, Interview with the Experts, the Intersection of Cardiovascular Disease and Female Reproductive Health. Today's topic is menopause management in women with cardiovascular disease. And it's my great pleasure to introduce someone who is an absolute renowned expert in this field. Dr. Chrisandra Shufelt is a professor and chair of the Division of General Internal Medicine at Mayo Clinic in Jacksonville, Florida, and she serves as the associate director of the Women's Health Research Center across the entire Mayo Clinic enterprise. She is a board-certified internist who completed her fellowship training in vascular biology and women's health and is currently a certified menopause practitioner. She holds both national and international leadership roles with organizations including the European Menopause and Andropause Society and the Menopause Society, which was formerly the North American Menopause Society, where she served as president in 2022 and is currently on the board of trustees. Dr. Shufelt has authored more than 200 publications focused on women's health and has co-authored several key scientific statements on menopause and hormone therapy, including serving as the lead author on the 2023 Non-Hormone Therapy Position Statement for the Menopause Society. Her NIH-funded research investigates cardiovascular and immune health in young women with hypothalamic amenorrhea, as well as the impact of menopause on cardiovascular health. And I truly cannot think of a more qualified expert with us today on this topic. Thank you so much for taking the time to join me today.
Oh no, thank you, Dr. Tweet. And that was a fantastic introduction. It's a little overwhelming when you hear back on your history, but thank you so much for having me. And I'm always a pleasure to talk about the intersect between hormones and heart disease, as this has kind of been my life's passion throughout my whole training.
Awesome. So perhaps we'll just start basic because this is a question I think about in my clinic. Are there menopause-specific factors? So premature menopause, chemotherapy-induced menopause, severe vasomotor symptoms that independently increase cardiovascular risk, or, even just what cardiovascular risk factors are attributed to ovarian aging, so menopause, rather than just aging overall?
Yeah, absolutely. So you bring up a good point, is that does the timing and type of menopause impact cardiovascular risk? And truly the answer is yes. And this is really interesting history, really, that came out of the Framingham study when they looked at women that went into menopause early, which truly early menopause is defined as women who enter menopause between the ages of 40 to 45. And premature menopause is women who enter the age under 40. The natural age of menopause in the United States and most Western countries is 52 years of age. And menopause certainly can be a natural or it can be surgical when you have your ovaries removed. And now we also recognize that there's a lot of medications, including chemotherapies, that can cause chemopause or just a chemically induced menopause. So there has been consistently, from the Framingham study to the Nurses' Health study to a lot of these large observational studies, even out of Europe, that find that there's higher rates of coronary heart disease, stroke, heart failure, even cardiovascular mortality if the women that enter early and premature menopause. Now, over the long term, what we do know is these are women that are physiologically different than women that enter natural menopause. And only a few studies have looked at, is there a mitigation if you give hormone therapy? And there is. So we need to think about those are different women that are entering menopause at an early age, as opposed to a woman that enters at 52. And is that when estrogen should be appropriate in some women. But there is also a difference between ovarian aging and natural aging in terms of cardiovascular risk. But we certainly know that there's an inflection point at menopause for cardiovascular health. And certainly women come into my clinic being evaluated for their hot flashes and night sweats. And I do a cardiovascular evaluation, and I might hear them say, I've never had high blood pressure in my life. My lipids I've never been told I had high cholesterol before. And that is truly an inflection point. Now, does blood pressure change during menopause? Blood pressure changes and increases in midlife. And at 60 years old, about 70% of women, as you know, have high blood pressure. And we know that estrogen is a very potent vasodilator. So lower estrogen levels are associated with higher angiotensin converting enzyme activity. And so there is a certain percentage of women that enter menopause that have that sensitivity. Not all of them do. So the answer for that is some are associated with chronological aging, blood pressure, and some are associated with ovarian aging. You mentioned lipids. Does lipids change during menopause? And during menopause transition, which is surrounding that final period, so years before and years after, there is an unfavorable shift in lipids that occur independent of age. So total cholesterol and LDL start to more rapidly change the following year past the final menstrual period. And interestingly, findings from the SWAN study, so the study of women across the nation, have really found that HDL, where women enter usually menopause with very high HDL, but HDL function may become impaired during menopause. So rendering it really less cardioprotective. So that's where I always hang my hat and say, don't just say I can't go on my statin because I have so much good HDL around, because it might not be as functional as it was during your reproductive years. Now that's an observational study. It still needs to be more vested out, but they've actually associated that having a high HDL at menopause has been associated with more carotid structural changes as opposed to LDL, believe it or not.
Okay, so with that in mind, should we be putting all women who enter menopause on hormone, like menopause hormone therapy? Or I guess, what does the current evidence suggest, or how do you decide if your patient is an appropriate candidate? Because it sounds like going through menopause, there are a lot of cardiovascular effects that sound overall negative. And certainly you mentioned the early menopause aspects too. So should we be just considering putting all women on menopause hormone therapy to try to prevent that? What's the data there?
Yeah, and this is actually the great epidemiological hypothesis that brought about the Women's Health Initiative, is that women at menopause, accelerated cardiovascular disease. What happens at menopause? The loss of estrogen. Therefore, let's just replace estrogen and prevent heart disease. And that's really why, before the Women's Health Initiative, it was the most commonly prescribed medication really on the market. Almost 40 to 60% of women were being given prescriptions for hormone therapy at the time of menopause. And if we thought estrogen was cardioprotective, do you want to know who they studied it in first? They studied it in men. They gave men with atherosclerosis back estrogen and kept them on it. And actually, there was an increased risk of MI and PE. So they stopped that study, but we still hadn't answered that in women until the Women's Health Initiative. And to answer your question about should we just put every woman back on hormone therapy for primary or secondary prevention, that's really, we really are not recommending that. It's not part of our current guidelines. It remains effective for treatment of symptoms, menopausal symptoms, in appropriately selected women. But we do know that when we initiate it even late in menopause, then there may be an increased cardiovascular risk when you start hormone therapy. But to say that we would treat lipids or we would treat blood pressure, we don't see that relate into prevention. It might make us feel good or it might make our numbers look a little bit better, but it hasn't translated in large clinical studies to prevent cardiovascular disease events. So that's one of the reasons that menopause hormone therapy is not recommended for primary or secondary prevention. And that's been shown in large clinical trials and as well as observational trials to date. And, we also know, and here's the good news. This is the good news. Hormone therapy doesn't increase the risk of cardiovascular disease in women at and around the time of menopause. So that's why I say that we're not using it for prevention, but for a majority of women, hormone therapy can be an effective treatment for vasomotor symptoms and can be used safely in terms of overall risk.
That's good to know. Now, let's say I have a patient in my clinic who has had a prior heart attack, for example, related to atherosclerosis. Would that be a patient, that you would treat with menopause hormone therapy, or would you try other medications first? What are your thoughts there? Because, if you look at some of the information, or even if you look at the package insert, there's some concerns, and we'll talk about the black box warning in a little bit, but what are your thoughts there?
So there are some true contraindications to being on hormone therapy. And while we do recognize there's several different types of myocardial infarctions, a thrombotic event it is recommended not to use hormone therapy. So if a patient's had an MI, then we do not recommend hormone therapy. Other things like pulmonary embolisms, VTE, as well as estrogen-sensitive breast cancers, severe liver disease, those are also really contraindications that have been outlined in guidelines that we don't want to use hormone therapy in those women. But in terms of treating their symptoms, we don't want these women to just continue to have hot flashes and night sweats. There are several good non-hormonal treatment options that are available. So it's not that you have a patient come in and say, you can't go on hormone therapy. Goodbye. We have very good evidence to show, and now actually three FDA-approved indications for non-hormonal options for hot flashes and night sweats. So one of the first is coming out of the cancer literature. We know that the SSRIs and SNRIs work very well in some women, and you can kind of get a 2-for-1 if the woman has some challenges with things like mood or anxiety at the time of menopause. And really, it's about where the area of the hypothalamus that controls thermoregulatory perception, serotonin, under control by serotonin. That's why the SSRIs and SNRIs do work. The other, and there is one on-label indication, paroxetine at 7.5 milligrams is on-label by the FDA. The others are all off-label, but what we know from the oncology literature is they do work. Oxybutynin has become kind of a newer one that actually works more recently out of the cancer literature as well in the last few years, and really put on the non-hormonal position statement guidelines as an option for younger women. Of course, we want to be cautious about long-term use in older women because of some of the associations with cognition. But for some women at the time of menopause that are having severe hot flashes that can't go on hormones, they do work. Gabapentin is another one at nighttime can work. Caution around somnolence, but some women need that for help with their somnolence. And then finally, we have two new FDA-approved formulations that work on a different mechanism. They work on the kisspeptin, neurokinin, and dynorphin pathway. This is the KNDy neurons. And the KNDy neurons are a clustering of neurons that sit in the hypothalamus that actually control the area of the brain that controls hot and cold perception as well. So this is fezolinetant and elezinitant, and these are two new options. And quite frankly, I've had one patient say, I didn't know what life was like without a hot flash until I started this medication. So both of those are very effective choices. There's some recommendations for, because they're relatively new, for liver monitoring, but otherwise they can be prescribed with a lot of the common medications that we use in cardiovascular health.
Oh, fantastic. I'll sometimes have patients ask about supplements. How do you respond to patients' questions about supplements when they bring those up?
Yeah, so it's interesting. Supplements, I always say there's a lot of claims that you can make with supplements, and you can base it on symptoms. And we did a deep dive into the supplement industry world, as well as some of the natural herbal supplements, as well as just vitamins. And there's a very large placebo effect. It's around 30%. So if I have a patient on a supplement, I really ask, how long have you been taking it? I look at safety of their liver function, what they're on currently in terms of other medications. But to me, if it's not giving them more than 30% effectiveness, it's really not any more than placebo. And that goes to show you that there's a lot to be said about relaxation and mind as well, because we know cognitive behavioral therapy can be effective treatment for hot flashes. And so in general, we do not recommend supplements for treatment of hot flashes and night sweats.
You mentioned earlier the FDA, and as we're both aware, the FDA recently removed the black box warning for menopausal hormone therapy. What are your thoughts on this, and how do you think this will affect prescribing practices and patient decision-making?
It's an excellent question. And first of all, we're talking about menopause hormone therapy. So we are making strides right there. And people are talking about it online. They're going into their doctors and talking about it. We're about to publish in Mayo Clinic Proceedings a very large study looking at the last 2 decades of prescribing patterns since the Women's Health Initiative. And guess what? They're dismal. Hormone therapy prescribing patterns are still less than 5%. In fact, it was 2.7%. So if every woman enters menopause, and a majority of women are having hot flashes and night sweats, yet our prescribing patterns are still dismally low and have not changed since the Women's Health Initiative findings. So I think and so what the Women's Health Initiative findings, which were done, the findings that had an increased risk for things like breast cancer and stroke and dementia, which is on the black box warning of all estrogen formulations, whether it's topical for vaginal health or whether it's systemic in the form of pill and patches, every estrogen that's approved by the FDA has that black box warning on it. And so what the FDA has done is they made a recent decision to remove the black box warning on at least the estrogen formulations for menopause hormone therapy. And I think most doctors agree with this, that this is a good thing to move women's health forward. But in making the announcement, they really suggested that women could take this drug for long-term benefits for heart and brain, and we're just not there yet. I do think that there's a lot of concern around, I would prescribe vaginal estrogen, and 6 months later would see a patient come back and she hadn't started it because she read a black box warning saying this might cause dementia or a heart attack or breast cancer, when very minimal is absorbed when you use it for vaginal dryness and it's topically applied. And then, but the flip side is that when you use systemic hormone therapy, we can't say that there's a benefit for dementia or there's a benefit for cardiovascular, there's possible benefit for cardiovascular in some women, but it's really uncertain. We don't have the full claims to say that. So my take on this is it is a good thing for women's health that we're talking about it. We have dismally been prescribing hormone therapy across the United States for the last 2 decades. So if it is opening up the conversation by removing that black box warning, then that's a good thing. But I don't think we can't say that these are going to be claims about prevention or long-term health.
You commented on, vaginal estrogen or like an estradiol patch. And, we were talking earlier about women with cardiovascular disease, and knowing that those have minimal systemic absorption, do you ever consider using those for vaginal dryness, say in a woman who's had a prior heart attack, or do you avoid those as well in addition to avoiding the systemic hormones?
So if you were to put hormone therapy into 2 buckets, there is the women that need hot flash and night sweats and other symptom control. Those are systemic estrogens that can be given in an oral estrogen tablet or a transdermal patch of estrogen. And if a woman has a uterus, she must have progesterone or progestational agent on board, usually progesterone. That is one bucket. The second bucket is a topical vaginal formulation that just treats vaginal dryness, or what we term genitourinary syndrome of menopause. Big name, genitourinary. That also covers the urinary area because we recognize that vaginal dryness isn't just sexual health. It can also change the pH and make a woman more vulnerable to things like UTIs, bladder infections, and other infections. So if I have a woman who's had an MI or has contraindications to systemic hormone therapy, so the patches and the pills, then I certainly ask about vaginal dryness because I can safely prescribe topical vaginal estrogen. And that is a very estrogen dominant tissue. And after menopause, about 50% of women has thinning of that area. And the one thing that will bring that tissue back is that topical vaginal estrogen. It doesn't go systemic to the level of a pill or a patch. Very minimal gets absorbed. And studies haven't shown it associated with things like breast cancer or dementia. And in fact, our oncology colleagues are very selective and also use it in some women who've had an estrogen-sensitive cancer. It is an important component of women's health. And so just because we have these contraindications to systemic hormone therapy doesn't mean the contraindication should be for local hormone therapy. And I tell my patients, it's like the lotion you put on your legs this morning is going into your bloodstream. It's not, it's going into the tissue and it's supporting the health of that tissue. And I think midlife women's health is also important to be talking about midlife sexual health. And that's a very large component of sexual health in women.
Thank you for making that clarification. That's very helpful and also really an important topic. I recall a patient of mine who was having frequent urinary tract infections, and you can correct me if I'm wrong, but her vaginal estrogen seemed to help quite a bit with that. I don't know if that's something you regularly use in practice, but um, another question, and then we'll be wrapping up. As you may or may not know, I care for a lot of patients with SCAD, and there's a lot of controversy about hormones in that group. And we won't go into that in great detail because of the interest of time. But when I see these patients, knowing that there's very minimal data and thinking about these different approaches to menopause symptoms and so forth, are there any patients where we could be doing more harm than good with withholding systemic hormone therapy? And the reason I bring that up is, let's say I have a patient with premature menopause in my clinic who is not on any kind of systemic hormone therapy. Should I be considering that in that individual despite their history?
So, are there populations of women where we're doing harm by not replacing their hormone therapy? And the answer is yes. So, it's exactly who you just described. It's the women that enter premature or early menopause. These women need to be, this is where we can really use the term replacement. If you look in the literature today, most use the term menopause hormone therapy because the term has been sunsetted, hormone replacement therapy, because it's not that all women need to be replaced. But if you look at the women that enter via early or premature, whether it's natural or surgical, those are women that are physiologically different than a woman who enters menopause naturally at 52. And the way I describe this, and premature ovarian insufficiency also falls into this category because that is a form of early or premature menopause. And the way I describe this to my patient, if I have a 26-year-old who comes in and has premature ovarian insufficiency, I have to say, if you take you next to your best friend, your female best friend, and she's going to have estrogen in her body through the age of 52, and you are not. And we know there's implications for bone. Bone health diminishes after menopause. We know now from these large cohort studies that there is implication for cardiovascular, higher risk for cardiovascular risk and cardiovascular mortality, as I mentioned, stroke and heart disease and heart failure. So those are the women that we do want to replace. And we don't just want to replace because sometimes they're not having symptoms. They're not having hot flashes or night sweats. So regardless of not having symptoms, I replace them back to a physiological level of estrogen. As opposed to menopause symptoms, I can use a smaller amount and treat their hot flashes and night sweats. So what is a physiological amount in a woman that's in her, let's say in her 30s, that goes into premature menopause? It would be a patch or a pill of estrogen it is in that systemic bucket that it gives an average of what that woman's natural cycle should be, an average estrogen. And that average estrogen is around 100 over a 1 month cycle. So that's where a 0.1 patch is good, or 1 to 2 milligrams of estradiol, oral estradiol. And those are replacing exactly what their body used to make. They're just not making it anymore. Obviously, with a progestational agent needs to protect the lining of the uterus. But that's how I explain it to my patients, because we are doing harm to those women that are entering that premature state of estrogen loss. And those are the women that we do. Now, the other areas of MI, if it's not a thrombotic event, if it's coronary microvascular disease, if it's Takotsubo, we don't have enough research in this area yet to say giving back estrogen might be a benefit to them. But what I can say pretty confidently is when you use a patch of estrogen and go through the skin, you do avoid first pass metabolism in the liver. So you don't get a lot of inflammation and the potential for blood clotting factors to upregulate. So if I have a woman who falls into an intermediate risk for cardiovascular disease, I always choose the transdermal route of delivery in the form of a patch, and that's consistent with guidelines. Progestational agent, so progesterone, it doesn't have to be through the skin. It is a pill. In fact, transdermal progesterone is not FDA approved as a route. Progestins are, but that component of hormone therapy doesn't play a role into the cardiovascular. It really is certainly is the estrogen component.
And if you use a transdermal estrogen patch and a woman has a uterus, you should still give them supplemental progesterone. Is that correct?
Yes. And here's the beautiful thing about progesterone. Progesterone at night we dose it at night. It is, and the standing dose is 100 milligrams, sometimes 200, depending on the formulation used. It is a sedating hormone. It helps you sleep. So that's one of the benefits of the side effects that you get from progesterone. But again, it also is a peanut-based product, so you can't have a peanut allergy, cross it over sometimes to sesame. So a lot of minutia that goes into hormone therapy. It's not one size fits all. It's not that every woman should be on hormone therapy, but this is the opportunity to really find an expert and ask these questions. And it's also an opportunity for cardiovascular prevention, because I think that what women do in their midlife for cardiovascular health and being aware that some of the cardiovascular risk factors increase during menopause transition, and it's an opportunity to help prevent things that are going to happen 30 and 40 years from now, because we certainly know longevity is there, lifespan is there, and health span is just as important.
I cannot thank you enough for the time that you've taken, and I've learned so much during our short time here together. Thank you for presenting a very complex topic and answering difficult questions in such a clear manner that is easy to digest for those of us who do not make these decisions every day with our patients. I really appreciate the insights you've given us today. Do you have any parting words for our listeners?
Well, I think my parting word is menopause matters, and it's important to talk about it. It's important to talk about with your patients, whether you're a cardiologist, an obstetric gynecologist, an internist. It's just an important phase of a woman's life that every woman will go through.
Fantastic. Well, thank you again for joining us today. And to our listeners, thank you for tuning in. And I hope that you listen to our other topics in this series. Take care.
At Mayo Clinic, learning fuels world-class care. I'm Dr. Peter Noseworthy, Chair of the Division of Cardiac Electrophysiology. I hope you enjoyed today's episode, and I want to let you know about the full courses that we have available. Head over to cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses. Join the thousands of clinicians who have already turned their curiosity into expertise at cveducation.mayo.edu.